Good morning. I'm delighted and honored to be here. First, I'd like to thank Dr. Au, Professor Poon, and all the organizers for the invitation and hospitality to this exciting meeting. As the first speaker of the symposium, I took liberty to modify the topic a little bit. I guess I'm a year late to the symposium, and focus on some of the clinical issues that we're facing in the treatment of liver cancer from the precision oncology standpoint. As a clinician, I have firsthand experience in dealing with some of the challenges that we face in the clinic. And towards the later part of the talk, I would propose some potential solutions to overcome these barriers. So let me start with a very simple definition that I try to keep in mind when I talk about precision medicine. And that simply is the practice of medicine that matches the right treatments to the right patients. So as you can see, depending on your personal context, it has many different meanings. For example, as a liver surgeon, we try to target the lesions in the liver as precisely as we can. And for example, in this particular patient of mine, she had 7 separate metastatic disease in her liver, and that I treated about 12 years ago with a combination of surgery and ablation. And luckily, she's still alive and free of disease. But you can interpret this as a form of precision medicine. But today, my focus is more on the systemic therapies, the selection of drugs that precisely target tumors. And in the area of hepatocellular carcinoma, until recently, there's only one drug that is FDA approved in the United States, which is sorafenib. So the choice there is not very hard. You either treat with sorafenib or you don't. But then it is not very precise. This past year, a couple of other drugs have now been approved, and there are several more that are coming down the pipe within the next year as well. So the choices will become more challenging, I think. So take, for example, in the case of colorectal cancer, stage 4, there we have about 11 FDA-approved drugs that are currently available in the States. So if I were the patient, I would ask, of all these drugs, which one or combination of these works best for my tumor? All right? And there's no easy answer to that. Traditionally, oncologists would go by the results of large clinical trials, which ends up setting guidelines. For example, the NCCN guidelines that we follow in America. But I think we can do better. More recently, of course, there's introduction of molecular markers, such as in the case of colorectal cancer, the RAS mutations and microsatellite stability status to help guide the treatment. So if all the cancers are the same, then I won't be having this discussion with you. So implicit in the term precision oncology is that of tumor heterogeneity. And that, too, happens at many different levels. At the broadest level would be on the patient side, their demographics, age, gender, ethnicity, where they live, the social environment, the microbiome, their intrinsic organ reserves. I would argue that even their insurance coverage has a significant impact on what treatments they can or cannot receive, and therefore the outcome. But that heterogeneity aside, for today's talk, I'm going to focus more on the tumor and its microenvironment, which, as you all know, also composed of a lot of different cells. Many of them will be discussed today, in particular the tumor cells. But for each of the cell types, we can further deduce a lot of data, both genetic, epigenetic, at the transcriptome level, proteomics, and metabolomics. So how do we integrate all that information together? So let me illustrate this with liver cancer. So this is a paper published from a European group led by Jessica Zucun-Rossi, who did a whole exome sequencing of, I think, 240 resected hepatocellular carcinoma. And this is not very different from other publications that have looked at this. And the bottom line is you can more or less sort them out into roughly 10 different pathways, as shown here. But I would submit to you that by looking at this, you would have a difficult time trying to figure out what is best for that particular patient with a particular genetic alteration. The second point is that even though there's so many genetic alterations found, only a handful of those are druggable, and these are highlighted in the yellow boxes that you see up there. So let me focus on that specifically. So here, most of them are either receptor tyrosine kinases and their downstream signaling pathways of MAP kinase and the PI3K, AKT, mTOR pathways. So let's dig deep a little bit here and see how well this paradigm works. In other words, if you identify a mutation, would you then say, well, let's treat with a drug that is indicated here? So I'm going to go back to some preclinical work that we and others did using animal models of hepatocellular carcinoma. And we and others have shown that the PI3 AKT mTOR pathway clearly is involved in liver carcinogenesis in the mice. In fact, when we put the two together, both upregulation of AKT and mTOR, you see an exaggerated phenotype, and the mice die very early due to severe involvement of the liver. So from there, we would say AKT mTOR are key drivers for liver carcinogenesis. And the implication is that if you block those key signaling nodes, you should derive therapeutic benefits. Well, Nassim Hay in Chicago last year published a paper where he tested this hypothesis. That is, if you then delete AKT, and there are two isoforms in the liver, AKT1 and AKT2, what happens? To their surprise, these double mutant AKT deleted livers, they also produce cancer at a very early age. And they went on to show that as a result of the AKT deletion in hepatocytes, they die, they cause inflammation, and subsequent activation of key pathways that promotes liver carcinogenesis, including the IL-6, TNF-alpha, STAT3 pathway. So what we're seeing from the preclinical work is that if you have too much AKT, mTOR, it causes cancer. If you have too little, it also causes cancer. They further treated their mice with an AKT inhibitor pharmacologically, like MK-2206. Same thing. So you said, well, maybe that's too potent. Let's bring it down a level and go to a downstream target of AKT and just focus on mTOR complex 1. Well, we did that in our animal models with either the TS1 knockout or the P10 knockout and treated those with rapamycin. And what happens is that, yes, the AKT knockout mice tumors, they shrunk and they died. On the other hand, the P10 tumors, they live happily as if nothing happens. So what that tells me is that inhibition of targets within a pathway can lead to different outcomes. Okay. So coming back to this picture here, the point is, I think, just looking at the genomic alterations and aberrations, I don't think is sufficient to guide clinicians how to treat or not to treat. We need some additional information, and I propose to you that is the functional component that is missing. So where do we start? Well, one of the approaches is to treat patients with cancer that falls into certain category of mutational abnormalities. So such basket trials, I'm sure you're aware of this. This is one example. This is the NCI-sponsored MATCH trial. This is a phase 2 precision medicine trial, and the primary objective is to document the proportion of patients with objective response. So they match, they sequence the patient's tumors and match them with a set of drugs. I think there are 19 different arms here. But as I already alluded to, my guess is that you're not going to get a huge response in any one of those categories. But if you do enough of them and then derive very rich clinical and molecular data, at some point you should be able to analyze those and come up with relevant biomarkers and predictor of response. But that may take some time. As of today, what do we see in clinic? I think it is relatively straightforward to obtain omics data, especially at the DNA level. It's very straightforward. And you can get a table like this at the end of the analysis showing you all the various mutations in that particular tumor, and that is an actual case. The problem comes as a clinician is how do you make sense of that in order to guide treatment? And there, I think it's really just an educated guess at this point. Okay. So how do we overcome this significant challenge? The way I see it, there are sort of two different approaches. In the first one, you're trying to reduce, or we try to reduce, the complexity that I just showed you with respect to liver cancer. In other words, can we identify a subset of these cancer that is relatively homogeneous? They all share the same clinical phenotype, the same pathologic features, and even the genetic alterations. And then if you can do that, then you can dive deep in that situation and trying to figure out what's going on and trying to identify druggable targets. The second approach is, well, you said this is way too complicated. No two tumors are the same. So I rather focus on developing a functional assay that can interrogate the tissue and then inform the clinicians. So I'll give you an example each that we're working on. The first of this is a very unique type of hepatocellular carcinoma, so-called a fibrolamella variant. As you can see from here, the description of it, it is very different. They occur in young people without history of liver disease, and they have a very unique histology when the pathologist reports it. They have lots of eosinophilic granules with prominent nucleoli, and most significantly, they have these thick fibrous bands, and hence the name, fibrolamella. So this story unfolded in 2014. Sandy Simon at Rockefeller University did a whole genome sequencing analysis of these tumors and identified one and only one consistent alteration. That is a deletion, roughly 400 kb deletion on chromosome 19 that results in a in-frame fusion transcript that brings the first exon of a heat shock protein chaperone, DNA-JB1, fused to the catalytic domain of protein kinase A, pKa, absent the first exon. So as a result of that, the mutant protein is actually expressed at a higher level than the wild type in the tumor. And that's, we think, is basically just a switch in the promoter usage. The mutant product actually is quite similar to the wild type pKa in all respect. It doesn't disturb the kinase pocket. it only adds on the N-terminal domain. And we and others have shown that, indeed, the kinase activity at baseline is normal. So we took actual human tissues here and performed a protein kinase A assay. Unstimulated basal activity are similar to that of normal liver. However, upon stimulation with cyclic AMP, that activity goes up significantly. That said, this fusion kinase is not your typical proto-oncogene, in that if you have too much of the kinase activity, it drives proliferation and cell proliferation. In fact, when we turn on PKA activity in the human tumors, it reduces proliferation and growth. And the opposite is true when you inhibit protein kinase activity. So we're back to square one. We said, well, what's going on? So we decided to take a phosphoproteomic approach. And here's an example of one such result comparing the fibrolamella to a classic HCC. And the point here is that, yes, they do have overlapping kinases activated in both types of tumors. However, the connection between them are quite different. So let me just focus on one area, which is the PKA and how it activates ERK through a protein called KSR1. It turns out that cyclic AMP PKA complex with two scaffolding protein, the ACAP LBC and the KSR1, to promote growth factor signaling mediates through the RAS pathway. This is work done by our collaborator, John Scott. And indeed, when we look at the human tumors and the cell lines that we develop, we can co-IP with the mutant protein, heat shock protein 70, as well as the ACAP LBC. So they do form this signaling island. So to get at whether it alters the downstream activity of the pathway, we took an unbiased screen using a combination of drugs, one which blocks the activity of the heat shock protein in addition to a whole bunch of FDA-approved compounds. And this is done in collaboration with a local startup company called Sengen. So they're supposed to be, let me see. The format changed here. This was supposed to show you the results of that screen. I'll just explain it. So what we see, surprisingly and unexpectedly, that compared to the wild-type cells that you don't see here, the presence of that mutation leads to significant chemo resistance across the board. And here's one example that you could see, right? So we treated these cells with starsporin, which is a potent kinase inhibitor. It killed the wild-type cells at very low concentrations, but you can see the FLC cells are relatively resistant. And that holds true for almost all compounds that were tested. Importantly, when we block this function out here, and again, you don't see a thing here, it reverses that phenotype almost completely. So the FLC lines became as chemosensitive as the wild type. I hope the next slide is going to show you the actual data. Oh no, it didn't again. But you have some circles. So specifically, we found, interestingly, that there's a cluster of these compounds in which the FLC lines became exquisitely sensitive upon inhibition of the heat shock protein function. And they all belong in the PI3 kinase inhibitor class. So here's a specific example of that. You can see is drastically sensitized. So our current model is to suggest that the pKa, in addition to the scaffolding proteins that you see here, works in conjunction with the heat shock protein complex to induce cell proliferation and survival. And upon inhibition of that function, it exposes certain vulnerabilities of these cells, such as the pathway, which then becomes druggable. If this model is validated, then one can perhaps start thinking downstream and perhaps translate that into a clinical setting where we can do dual inhibition in this particular subset of HCCs. So I show you this as an example where you can sort of go deeper once you know the specific mutation in an otherwise very homogeneous disease. Of course, that doesn't happen most of the time, like 99% of the time. So for all the other HCCs, we try to develop a functional assay to test sensitivities. And I'm sure you all know there are various patient-derived cancer models shown here. I try to highlight that none of them is perfect. They all have certain merits and limitations. Take, for example, the PDX mice. They're great for in vivo modeling, but as you know, it takes months to develop a line in order for it to be tested. So from the clinical application, from a patient standpoint, it is relatively irrelevant. So when we turn to the more time-sensitive models, we have organoids as well as organotypic culture. My bias is to think that the combination of the two may provide a path forward to guide personalized therapy. So in terms of an organoid system, as I mentioned earlier, there's a local startup called Sengen where they develop short-term primary organoid from core biopsies or surgical excision, and then put them through the high-throughput screen, and they can do all this within a 3 to 4 week period, which is relatively responsive and clinically relevant. And here's an example of two primary liver cancers that was done this way, this case and that, looking at the differences, and you can see that for many of the drugs, they are very different. Take, for example, lotinib was much more sensitive for this line and not this tumor, and the opposite for a BCL2 inhibitor, which is reassuring that indeed tumors are heterogeneous. What is also, I think, interesting is that even within one class of drugs, say PI3K, we found that mutation in this patient, let's say, they can behave quite differently depending on the specific compound that we use with the presumably same target. So without functional assays like this, we would not have been able to pick that up. We have also been working on a slightly different platform. It's an organotypic slice culture. And here we simply take the tumor, slice it up, and put it in vitro and see. And this is not new, but we just have modified it and standardized it, if you will, so that we can compare between different slices and different cases for comparison. And most of them do survive for at least a couple of weeks, so you can manipulate them in vitro. And I think the most important part of this is the fact that they retain the entire tumor microenvironment in its original three-dimensional context. Of course, this only works for solid tumors. And then we can test. Here's an example of a pair of HCCs exposed to sorafenib, and you can see that there's a responder in one and a non-responder in the other. Of course, it's hard to clinically validate these in the absence of a prospective clinical trial. All right, I just want, okay, one more thing. But we could use certain baseline data that is, I think, clinically relevant. For example, how active there at baseline when we first take them out does correlate significantly with the pathologic necrosis score, as well as the nodal status of the disease at the time of resection. Let me show you this one interesting case where this is a patient with colorectal cancer that we took care of. And the patient underwent neoadjuvant chemotherapy, and she had 2 lesions. You can see this one responded to chemotherapy, whereas an adjacent one did not. Obviously, same patient, same time, same drugs, right? Such that at the time of surgery, the 2 were roughly the same in size. We took both of them out, analyzed them, and look at their response based on RNA sequencing. So here's by an unbiased type of analysis, we can actually sort out the responder from the non-responder using this platform. Before I leave this, I just want to emphasize, because it's a hot topic, the tumor-infiltrating lymphocytes are retained in these slice cultures, as you can see here. And they stay relatively stable over time. So here's comparing day 1 and day 6, the relative proportion of these cells, and the markers, I should say, they're relatively stable. So that would be another platform, perhaps, to test new combinations of immunotherapies. So lastly, I just want to take a very quick walkthrough of what we think is an integrated approach to trying to identify the proper targets as well as to validate it functionally. So here the presumption is that more information regarding the function of those molecular pathways, the better. So we bring in the proteomic side, in particular, focus on the kinases for HCC, because the drug that is currently FDA approved is a multi-kinase inhibitor, but we don't know which kinase. Right? So anyways, in collaboration with Xiaoying Ang in pharmacology, he developed a kinobeat reagent where he can pull down a very good representation of the entire kinome. And when we tested this in human liver cancer, again, in an unsupervised analysis, it can actually sort them out by etiology. Now, I think this is a little bit, this is very preliminary, so I wouldn't say this is real until we can actually validate it. Another component of our integrated approach is to identify the kinase pathways through what we call a kinase inhibitor deregularization process. This is in collaboration with another fellow in systems biology, Taran Garal, at our institution, where by exposing the organoids to a panel of like 30 different kinase inhibitors, he can then do target deconvolution to identify which pathways are upregulated. And in so doing, putting all that information together, we hope to then identify the key targets, which can then be validated in our slice culture. And then then the data from that, the results from that, feeds back in to a regression modeling algorithm to further optimize the targeting. So I will end by saying that this and many other different similar approaches using cutting-edge technology is forthcoming, and hopefully this will bring us a little bit closer to the bedside in terms of precision oncology. Let me close by acknowledging the folks that did the work in the lab, as well as my many collaborators. John Scott in pharmacology with the protein kinase A study, Xiaoying Ang, the phosphoproteomics, Raymond Yeung, the immunobiology of solid tumors, and 2 system biologists working on the project as well as collaboration from Senjin with Carla Grandori. So thank you for your attention.